I'd really like to thank you all for being with us today. And my name is ا.د.خليل. I'm a professor of ophthalmology at Malta University. Today we'll be talking about uveitis for medical students. So uveitis is a heterogeneous group of disorders which might be caused by infectious or non-infectious causes. The non-infectious causes are termed autoimmune diseases. The classification of uveitis can be divided anatomically into anterior uveitis, intermediate uveitis, and posterior uveitis. And the etiology can be divided into infectious and non-infectious causes. Infectious causes like viruses, bacteria, fungal, and parasites. Non-infectious causes are more or less caused by rheumatological diseases. Those are autoimmune diseases that can affect any part in the body. Uveitis can be classified according to duration. So we have acute uveitis, where the uveitis is less than 6 weeks of duration. If it's more than 3 months, this is called chronic uveitis. And finally, there is a recurrent relapsing disease where the uveitis actually comes and goes in an acute fashion. However, it doesn't fulfill the whole chronic criteria. Regarding signs and symptoms of uveitis, uveitis can come with redness, eye pain, light sensitivity, blurring of vision, and even the presence of floaters or dark spots. So now we'll dig deeper actually into the causes. First of all, we're going to talk about autoimmune diseases, infectious, traumatic, drug-related, and neoplastic, and masquerades or others. Regarding autoimmune uveitis, it can be divided into 3 major categories. The first is HLA-B27 disorder-associated diseases like psoriasis, inflammatory bowel disease, Crohn's and ulcerative colitis, ankylosing spondylitis, and reactive arthritis, or formerly Reiter syndrome. Also, we have vasculitic diseases such as Wagner's granulomatosis, or granulomatosis with cholangitis, polyarthritis nodosa, systemic lupus, and Behçet disease. Others, like sarcoidosis, juvenile rheumatoid arthritis, and Vogt-Quinn-Aguirre. The most common signs and symptoms that are seen with uveitis is the presence of redness, eye redness, and pain. So the redness is usually circumlimbal, or termed circumciliary injection, with the presence of KPs or keratic precipitates. The keratic precipitates, in some cases, might cause synechia, which is the presence of adhesions between the iris and the lens. Because uveitis is inflammation, the hallmark of inflammation is the presence of white blood cells. And these white blood cells, either they will stuck on the posterior surface of the cornea, causing the presence of keratic precipitates, or they may actually sediment down into the anterior chamber, causing something called hypopyon. Regarding the treatment of uveitis, usually there are some guidelines to follow while treating patients. For example, patients with anterior uveitis, we tend just to give them topical steroids along with topical mydriatics like cyclopentolate, for example, 1% twice a day, and sometimes we give them anti-glaucoma medication, which is necessary to lower down the intraocular pressure. However, oral steroids might be used also in anterior uveitis. Posterior uveitis is a little bit a different story. We tend to avoid giving steroids until we have a very frank diagnosis, because it is caused by a lot of infectious diseases. So giving steroid early in the treatment might end up the patient blind, secondary to excessive inflammation, which might worsen when you're giving oral steroids. So a rule of thumb, PPD skin test is mandatory in all granulomatous uveitis. And I mean by granulomatous those with motile fat KPs. Okay, so it's very important to do a PPD skin test, rule out the possibility of tuberculosis, because if you have TB, then giving steroid is it will cause the patient his life, and it will worsen the TB symptoms. And thank you so much for listening.